All right, welcome everyone. My name is May LaRue, and I am the Program Management Specialist on the Training and Education team here at the MaineHealth Center for Tobacco Independence. I'd like to welcome you to our ongoing webinar series. This is one component of our tobacco treatment and prevention education and training program, which is sponsored by and brought to you on behalf of the Maine Center for Disease Control and Prevention, Department of Health and Human Services. This webinar will be recorded and posted to our website following the presentation. We are offering one continuing medical education credit and one CHES credit for this webinar, which will be sent to those who attend the entire session. In order to claim CMEs, you must have a profile in Cloud CME. If you already do, you will find your credits in your profile within a week of this event. If you do not have a profile in Cloud CME, you can find instructions on how to make a profile in the post-webinar email. For those that are collecting CHES credit, record of your attendance will be sent to NCheck after the event. Only those who registered for the webinar, connected via the Zoom link, and attended the full session will be able to receive credit. At the conclusion of today's webinar, an evaluation will appear on your screen as well as be sent to you via email within 24 hours after the event. We encourage you to take the time to provide your feedback, as it is not only helpful to us in planning our webinar series, but to our presenter as well. Today's webinar is titled Tobacco Treatment with Low Socioeconomic Status Populations and is presented by Edward Perka of the MaineHealth Center for Tobacco Independence. Before we begin, all the phone lines have been automatically muted to help reduce background noise. We do, however, want you to participate in the session. Please type any questions you may have into the Q&A box. For your convenience, a copy of this presentation will be sent out via email after the webinar. And at this point, I would like to turn it over to Edward.
All right, thank you, May. So welcome everybody to today's webinar on tobacco treatment with low socioeconomic or SES populations. My name is Edward Perka and my pronouns are he and him, and I'm a tobacco treatment and prevention educator here at the Center for Tobacco Independence at MaineHealth. I'm an addictions therapist, actually practicing as a New York State credentialed alcoholism and substance abuse counselor for over 30 years. I'm also a tobacco treatment specialist, and I've been working in the tobacco arena since about 2008. I came to MaineHealth about 8 years ago, and I've been providing training and education about tobacco use and tobacco use disorder treatment ever since. And I'm very pleased to be with you today to talk about how we can help people improve the quality of their life by becoming tobacco free. It really is an honor and a privilege to be able to share this information with you. So while time doesn't permit us to really properly introduce ourselves, I do invite you to use the chat feature to let the group know a little bit about you. So if you want to share your name, first names are okay, pronouns if you like, where you work, what your job role is, and just for fun, maybe something interesting about you. For example, I did introduce myself just now, but something interesting about me is that I've also been an acupuncture detoxification therapist. Just a quick note, we'll be referring to the people we work with as patients or clients. So you may call them participants or residents or members or something else. So please be assured that when we say patients or clients, we mean everybody. Okay. So let's get started. I first want to tell you about the mission of the Maine CDC Tobacco Treatment Initiative. The MaineHealth Center for Tobacco Independence, or CTI as we call it, has served as the primary contractor of the Maine statewide tobacco treatment initiative since 2001. We administer the Maine Quit Link, which is our state quit line, and deliver provider education and training, which is where you are right now. Our training and education program is nationally accredited by the Council for Tobacco Treatment Training Programs and offers the training pathway for those pursuing tobacco treatment specialist certification. The Maine Quit Link offers free coaching provided by certified tobacco treatment specialists and also free nicotine replacement medications known as NRT for all Maine residents. And our training in for healthcare professionals includes the essential skills training, the intensive skills training, the annual Tobacco Treatment and Prevention Conference, provider outreach, technical assistance, and a selection of specialty trainings, webinars, online courses, and sound bites. The sound bites are for those of you who like the podcast format, and May actually does those sound bites for us. As we gather in this place, we want to acknowledge that we are occupying the traditional territory and ancestral lands of the Wabanaki people, who for thousands of years have called this place home. We acknowledge their continued connection to this land, give thanks for allowing us to do this good work on their homeland, and remember their ancestors who were here before us. Indeed, let us acknowledge all the indigenous people and their homelands in this nation west from here, on which millions of us live and which we all call home. And I also want to mention that references to tobacco in this presentation refer to commercial tobacco use and not the sacred and traditional tobacco use by American Indian communities. And let me share a disclosure statement. All planners, faculty, and others in control of the content of this educational activity have no relevant financial relationships with ineligible entities, that is, commercial organizations. And these are the objectives for today's training. We want to explore smoking prevalence rates and burden among low SES populations. We want to define evidence-based tobacco use disorder treatment, which I'm going to be referring to as standard care. And then we're going to outline the risk and protective factors unique to the low SES population. And then finally, we'll present enhancements to usual care in engaging and treating low SES individuals, which I'm going to refer to as standard care plus. So I know that most of you are probably familiar with this alphabet soup of acronyms, but bear with me for a minute while we review this. I might not get to all of the explanations in the course of the conversation, so I wanted to put them here up front. So we have CBT, cognitive behavioral therapy. CTI is, of course, the Center for Tobacco Independence. EBT, evidence-based treatment. MI, motivational interviewing. NRT, nicotine replacement therapy. RPT, relapse prevention therapy. SES, of course, socioeconomic status. SUD, substance use disorder. TAG, tobacco awareness group. TRG is tobacco recovery group. And of course, TUD is tobacco use disorder. I also want to mention that while this training focuses on low-income individuals, that's only one factor in a whole array of social drivers of health. So when we talk about treating tobacco use disorder and treatment planning, we're also taking into account, for example, educational access and quality, healthcare access and quality, the neighborhoods and environments and the social community contexts that our clients exist in. So low SES is just one slice of the pie, but it helps to pull it out a little bit and examine it in its relationship to tobacco recovery. Okay, I'd like to ask you this question. You can use the chat feature to respond. On a scale of 0 to 10, with 0 being no confidence at all and 10 being as confident as you can possibly be, how confident are you right at this moment that you have the knowledge, skills, and abilities to effectively help low-income clients become tobacco and nicotine free? So I'll give you just a few seconds to respond. And let's see, maybe May, you could see what some of our responses might look like.
Yes. So I'm seeing a 5, 7, or 8, lots of 6s.
Okay.
More 5s, lots of 7s.
Gotcha.
6 or 7.
Okay.
8, 3 or 4.
Oh, okay. So we got a good grouping. All right. Now I have 2 follow-up questions for you to consider. Now don't respond to these, just think about them for a bit. Okay. And the first question is, why did you choose the number that you did? And then the second question is, what would have to happen for that number to go up by 1? Right. So you have your number. Why did you choose that number? Just think about this. and then what would have to happen for that number to go up by 1. So keep your number in mind, right? Because at the end of the presentation, I'm going to ask you the same confidence question again. It'll be interesting to see if that needle has moved at all. All right, so let's discuss the scope of the problem. So first, a warm-up question for you. You can use the chat feature to respond to this. In what year was the first Surgeon General's report published that definitively stated that cigarette smoking caused lung cancer? Okay, in what year was the first Surgeon General's report published that definitively stated that cigarette smoking caused lung cancer? And you can type the year in and not the letter. That would be easier. So let's wait again a couple of seconds and see what you think about this one. When did we first know definitively, empirically, that cigarette smoking caused lung cancer?
So we have lots of 1964s, Edward, but we
Mhm.
have all the other years have been mentioned as well.
Represented as well.
Yes.
Okay.
Yep.
Yeah, we asked this question a lot, so I am not surprised that we have lots of 1964s because that is actually the right answer. Yes, since 1964 we've known, and also some elements of heart disease as well, we've known since that time. But it actually has changed quite a bit since then, as we also know. So I thought that since that first release of the Surgeon General's report on smoking and health in 1964, I thought we should take a look at some of the prevalence today among people with lower income. So currently, the highest income Americans smoke at less than half the rate of those with the lowest income. And individuals who smoke and are low income are disproportionately suffering from these smoking-related diseases like cancer and stroke and heart disease and diabetes. So lower income people spend more, they suffer more, and they die more from tobacco use. And I don't think we can see this any more clearly than in this data. So if you look at under $15,000 a year, we see the smoking prevalence rate of 42.6%. Now, when I first looked at this data, I go, no, that can't be right. It's, that seems really, really high. But this is from the State Epidemiological Outcomes Work Group in 2020. So yeah, this data is right. And if you go over to our over $50,000 a year, we see the prevalence rates drops to about 9.8%. So individuals earning less than $15,000 a year have a smoking rate of 42.6%, while individuals earning over $50,000 a year have a smoking rate of 9.8%. So the average rate in Maine is 17.3. That's just the average. And while this is Maine data, this trend is most likely true in other states as well, I would hazard to say. So there are enormous and growing disparities in who smokes and who suffers from tobacco-related disease. Now, research released by the Brookings Institution revealed that the gap in life expectancy between those in the top half of the earnings ladder and those in the bottom half has grown dramatically for both men and women. Research published in the Journal of the American Medical Association found that for men, the richest Americans live nearly 15 years longer than the poorest Americans. For women, the richest Americans live 10 years longer than their poorest counterparts. Now, the tobacco industry is going to great lengths to target lower income and racial and ethnic groups. Through market research and aggressive promotions, the industry has successfully penetrated these communities, and the industry's investment in these communities has had a very, very destructive impact. So a logical question then presents itself. Where are these lower income tobacco users and these lower income communities located? So the answer is that they can be found in our most rural communities and counties. Did you know that Maine is considered one of the most rural states in the nation? I think it's like 2 or 3. According to the Maine CDC, 40% of the population of Maine lives in rural counties, and the smoking prevalence in rural counties is significantly higher, as indicated by the darker colors on the map. So why is this significant? So for a number of reasons, when you're assessing the best way to address treating tobacco use disorder among the low SES population, geography is a major factor in creating a plan. Issues such as availability and access to care, provider education and training, myths and misconceptions, bias and stigma, cultural considerations, and as I've mentioned, a host of other social drivers of health need to be considered. And we're going to kind of peek at some of those in a second. Now let's look briefly at the real life impacts, the real life disparities, and the real life burden among low SES individuals who use tobacco. So in 1964, as we've mentioned, the Surgeon General's report on smoking and health linked smoking with lung cancer and heart disease for the first time. 50 years later, in 2014, this graphic appeared in the Surgeon General's report. At least 15 kinds of cancer and 25 other chronic diseases are not only exacerbated by, but are caused by smoking. And I think it's safe to say that now, 10 years later, we know even more about the harms and burdens of tobacco use. So our understanding of the health consequences of smoking has evolved to the point where we know that tobacco use affects every major system and organ of the body. So health disparities are preventable differences in the burden of disease that are experienced by populations that have been disadvantaged by their social or economic status or their geographic location or their environment, or all of those things. And it's probably not a surprise to you that tobacco-related disease is the #1 preventable cause of death in the United States today. And the heaviest burden of tobacco-related disease falls squarely on the shoulders of lower-income individuals and other disparate groups. For example, cigarette smoking causes about 80 to 90% of lung cancer deaths in the United States, and people experiencing extreme poverty have higher lung cancer risk and higher lung cancer incidence than those in higher SES groups. And people with low SES are more likely to be diagnosed with diabetes. The risk of developing type 2 diabetes is 30 to 40% higher for people who smoke cigarettes than for people who don't. The American Lung Association has articulated what they consider the 10 worst tobacco-related diseases that people suffer from, and we can see them on our slide. It's not right, it's not ethical, or it's not moral to have some people bear the burden of these terrible diseases just because they don't have the same resources as other groups. So health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. So clearly we have much work to do in this regard, especially in those population groups that are most adversely affected by tobacco use and tobacco-related disease. So the next section presents an overview of evidence-based tobacco use disorder treatment, and you've probably heard some of this before. But we're going to call this standard care. So for those of you interested in learning more about tobacco use disorder treatment, CTI's, as I've mentioned, Tobacco Treatment Education and Training Program, offers self-paced courses, trainings in special topics, additional resources for continuing education in the field of tobacco and tobacco treatment. On CTI's website, ctimaine.org, you may access a variety of educational offerings such as tobacco treatment specialist training, self-paced webinars, self-paced courses, training for behavioral health professionals, and youth providers, and a large selection of video and multimedia offerings. This is my advertisement, by the way, if you weren't getting that. So visit our calendar of events for a listing of upcoming trainings. And for more information about current offerings or future trainings, you can contact Tobacco Training, that's Tobacco TRNG at MaineHealth.org, or 207-662-7154. I'm going to show you that contact information at the end of the presentation. So standard care, what is standard care? So what is evidence-based treatment? Evidence-based treatment for tobacco use disorders is well-researched, it's well-defined, it includes the combination of counseling and medication. Counseling includes both practical counseling and intra-treatment support. And don't get caught up by that word counseling Anyone can be a counselor. Anytime you provide guidance in decision-making to help people reach their goals, you're a counselor, regardless of your job description. Also, counseling doesn't have to be lengthy to be effective. A simple, brief conversation about tobacco is an effective form of counseling. So what do we mean by practical counseling? Practical counseling includes providing basic information about nicotine addiction, treatment methods, the use of medications to help with withdrawal symptoms, and relapse prevention planning. Practical counseling also includes helping people develop coping skills and helps them to learn how to deal with high-risk situations. So let me ask you a question now. This is just thinking cap question. You don't have to respond to this. When you talk with your patients and clients about their tobacco use, do they feel safe? Let me ask that question again. When you talk with your patients and clients about their tobacco use, do they feel safe? So intertreatment support involves creating a safe space where your patients feel comfortable talking about their tobacco use. This space contains no judgment, shame, or blame. In this space, providers are gently accompanying patients on their journey towards tobacco abstinence. Encourage your patients in their quit attempts. Communicate your belief in your patient's ability to quit, and encourage your patient to talk about the quitting process. Most importantly, let them know that when they're ready, you'll be there for them and that you can help them. So we developed this graph at CTI to illustrate how a client's readiness to change can drive your decisions on the best kinds of interventions and techniques to employ and which types of counseling methods might best serve their needs. And you can see some of the alphabet soup on this one. Just a point here about the reality of our work with clients. We know that if you ask 10 clients if they think it's important to quit, 70% are going to say yes. But if you ask those same 10 clients if they're ready to quit, maybe only 2 or 3 will say yes. And that tells us something really important. It tells us that the majority of clients we work with are most likely in what we call the contemplation stage of change. They're thinking about stopping, but they're not yet ready to put that thinking into action. And as you can see from the graph, a motivational interviewing approach, or MI, is going to best meet their needs. The techniques of MI, as a lot of you know, are designed to help people articulate and resolve their ambivalence and move in the direction of positive change. This process, of course, is different for everybody, and there's no time frame for resolving ambivalence. It takes as long as it takes. But you never know when that client is going to be ready to take action. I like calling it flipping the switch. But when it does happen, their needs are going to change. And at that point, our approach also needs to change. Now we're going to use more of a cognitive behavioral approach, or CBT, with clients, where we're helping them to discard that negative thinking pattern and embrace the power of positive thoughts and learn new skills to enable a lifelong recovery from tobacco and nicotine addiction using that relapse prevention approach, or RPT. The preparation stage of change is all about planning. It's no longer, do I want to quit? It's now, how do I quit? We're basically helping clients learn not only how to quit, but how to sustain that abstinence over the long term. And then the second component of evidence-based treatment, standard care, is medication. So the 2008 U.S. Public Health Service Clinical Practice Guideline treating tobacco use and dependence synthesized more than 8,700 peer-reviewed articles and contains 10 key recommendations for treating tobacco dependence. So let's look at these recommendations concerning the use of medications, right? First, medication treatment is effective across a broad range of populations. And by that, we mean that practically anyone in almost every demographic can benefit from using medications. Second, there are 7 first-line medications, 5 nicotine replacement, or NRT medications, and 2 non-nicotine medications that reliably increase long-term abstinence rates. A first-line medication is defined as an FDA-approved, safe, and proven effective medication. Third, providers should consider the use of combination medications. Combination medication has been shown to be more effective than a single medication alone. Examples of combination medication include using 2 NRT medications together, or combining an NRT and a non-nicotine medication. And fourth, providers should encourage every patient who is ready to quit to use medications except where contraindicated or where evidence of effectiveness is insufficient. Now, there's only one absolute contradiction for NRT, and that is called Berger's disease. Berger's disease is a rare disease that causes clotting and blockage in the blood vessels of the arms, legs, hands, and feet. People who get Berger's disease almost always smoke cigarettes or use other forms of tobacco, such as chewing tobacco. Quitting all forms of tobacco and nicotine is the only way to stop Berger's disease. And for that reason, patients with Berger's disease should not use NRT products. And then groups where evidence of effectiveness is insufficient include pregnant women, youth, light smokers, and smokeless users. This does not mean that tobacco treatment medications should never be used in these populations. If a provider determines that the benefits outweigh the risks, the use of medications in these groups should be considered. So, standard care, right? I'd just like to stress this point. Counseling alone is an effective treatment for tobacco use disorder, and likewise, medication alone is effective. But the most effective evidence-based treatment is the combination of both counseling and medication. So the chances of a successful treatment outcome are enhanced when these components are delivered together. So keep this in mind when you're working with your clients who are tobacco users. And then the 5 nicotine replacement therapies, well, again, also known as NRT, which I'm sure you have some familiarity with. The 3 on top, the patch, the gum, and the lozenge, can be purchased over the counter. The bottom 2, inhaler and nasal spray, require a prescription. All of these medications are safe and effective. And just a quick note here, at the current time, the nicotine inhaler is not being manufactured due to a shortage of materials used in the mouthpiece. But we did want to include it here as it may return to the market at a future date. Okay, so that's our standard care, right? So let's talk about some protective factors and risk factors. So we've discussed the prevalence and burden of tobacco use in the low SES population. We've outlined what constitutes standard care in evidence-based tobacco treatment. In this section, we're going to examine some of the unique protective factors and risk factors in the low SES population. But I want to slightly reframe, though, the technical and clinical language of protective factors and risk factors. Let's think about protective factors as things we can be optimistic about, things that are going to contribute to successful outcomes, and things that are already there, already present among this population. We can also think about them as strengths or resiliencies or motivations, or however we want to frame them. But we don't have to create them, all right? They already exist. Our job is to leverage what's already there and to facilitate it and encourage our clients to use it to their advantage. So that's the optimistic side. In fact, let's be optimistic about both sides. So instead of deficits or barriers or problems or risks, let's talk about risk factors as opportunities instead. Let's identify those areas where we can do better, like where we can think out of the box, where we can be innovative. So let's keep a positive and optimistic mindset about this discussion of factors. And as we go, as we talk about this, ask yourself, be thinking to yourself, what's already working in our favor? What are we doing well? What needs to change? What can we do better or do differently? And what needs to happen to move that needle in a positive direction? And then in the last section, we're going to discuss ideas for doing just that. For this population, what are some enhancements to standard care that we can implement that increase the chance for success? What are some of the things we can try? What ideas do you have? I'm going to want to hear from you on this. So there'll be a little time just for a brainstorming session at the end. So keep your minds open about this. All right, optimistic fact number 1. If you ask 10 tobacco users if they think it's important they quit, almost all of them are going to say yes. Notice that the question, again, is not, are you ready to quit, but rather, is it something that's important to you? And it is. And that is something to be hugely optimistic about. The desire is there. The relevance is there. The knowledge that tobacco use is harmful is already there. We can work with that, right? Our efforts are not going towards trying to convince people that quitting is important. They're going towards helping them to get ready, to help them to gain the confidence that they can do something they already want to do to assist them in achieving that goal. Optimistic fact number 2, more than 1/2 of smokers, regardless of demographic group, have made a serious attempt to quit, and that's being conservative. If you look closely at the data, including the confidence intervals, which are the little black lines at the end of the colored bars, you can see rates closer to 60% and even higher. So remember that this data shows actual quit attempts. That's people taking action and not just thinking about it. So are people motivated to quit? Yes. And are they trying to quit? Yes. Does it matter what their age, gender, income, or education level is? No. So let's not make any assumptions that low SES people don't want to quit. They do, and we should help them do it. So in case you're wondering, for this data, a quit attempt is defined as at least 1 day or 24 hours. Optimistic fact number 3, tobacco use disorder is a chronic and often relapsing disease of the brain where the primitive part of the brain takes over, and the result is compulsive drug seeking and drug use. We also know that withdrawal symptoms can feel unbearable. Now, that might not sound like an optimistic fact, but it's coming, right? The most popular method that people use to quit is not evidence-based treatment, but cold turkey, usually with no plan, no medications, and no support system. The success rate for cold turkey is only 3 to 5%. The good news is that effective treatments are available. We've already described what evidence-based treatment is. Now it's important for us to become educated and informed and to share that information with our clients who use tobacco. These treatments work, right? We know that they're safe and effective. They're available for us to use. So let's spread the word. Optimistic fact number 4, and following up on that idea, one of the best options that we have in Maine and in all other states as well is the availability of evidence-based treatment here in Maine through the Maine Quit link. Please visit the Maine Quit link to find out more, mainequitlink.com. And optimistic fact number 5, CTI also offers tobacco treatment training for healthcare professionals, including the essential skills training, the intensive skills training, a conference, outreach, technical assistance, webinars, sound bites. Again, visit ctimaine.org for a complete list of available training opportunities. An optimistic fact number 6, Stephen Rolnick is one of the creators, along with William Miller, of the therapeutic intervention known as motivational interviewing, or MI. One of the basic tenets of MI is that people are the experts of themselves. What that basically means is that people are inherently motivated toward achieving positive psychological functioning and a healthy lifestyle. That makes our job a bit easier, right? Since we're not forcing people to go in a direction they don't want to go. We're just guiding them along the way. We believe that people have the ability, the strength, and the resources to solve their problems, and we're going to encourage them and support them as they do that. So, and now, instead of thinking about risk factors, let's look at all the opportunities we have to make improvements in the way we provide tobacco treatment to our clients and our patients. And the first opportunity has to do with bias and stigma. So bias is a disproportionate weight in favor of or against an idea, a thing, or a person, usually in a way that is inaccurate, closed-minded, prejudicial, or unfair. Stigma is the disapproval of or discrimination against an individual or group based on perceived characteristics that serve to distinguish them from other members of society. So low SES tobacco users don't have a bad habit. They don't lack willpower. They don't have moral shortcomings or flaws in their character. They aren't the victims of self-inflicted wounds. All of these things have been used to describe them, and these descriptions are simply wrong. What they do have is a chronic, addictive, relapsing disease of the brain. It's the same disease that someone who is addicted to opioids has, or alcohol, or cannabis, or cocaine. They also share a disproportionate burden of disease caused by tobacco use, and they want to get better. They want to recover. They do want and need our help. The American psychologist Carl Rogers believed we must practice unconditional positive regard towards our fellow human beings. We must not be judgmental of someone based on their income or education or race or sexual orientation or lifestyle choices or any other characteristic. We have to strive to provide the best possible treatment to all. So I think all of us can examine our own biases and stigmatizing thinking in this regard to take a really deep personal inventory and identify and change some of that unhelpful thinking that might be getting in the way of providing that best care. And I just wanted to put that out there as food for thought. Opportunity number 2, all right, the most popular method that people use to quit smoking, as we've mentioned, is cold turkey. No plan, no medications, no support system. It's not surprising that the cold turkey success rate is only 3 to 4%. Going cold turkey is not an effective way to quit. The next question is, why are people not using evidence-based treatment? Here are a couple of possibilities. They don't know what it is. Patients don't know what evidence-based treatment is. Clinicians don't know about evidence-based treatment. So it's clear that our task is to become educated and informed about what works and to share that information with our patients who use tobacco. Remember that for the most part, patients want and expect you to ask about their tobacco use. We need to be prepared to help them when they're ready to stop. Opportunity number 3. Do you remember the 5 A's? Some of you that have taken trainings with CTI before or elsewhere, the 5 A's of brief tobacco interventions. If you remember, they're ask, advise, assess, assist, and arrange. Now, the National Institutes of Health also described access to care with a 5A model, and it is affordability, availability, accessibility, accommodation, and acceptability. So affordability is determined by the client's ability and willingness to pay for services. Availability measures the extent to which the provider has the resources, such as trained personnel and technology, to meet the needs of the client. Accessibility refers to geographic accessibility, which is determined by how easily the client can physically reach the provider's location. And accommodation reflects the extent to which the provider's operation is organized in ways that meet the constraints and preferences of the client. And finally, acceptability captures the extent to which the client is comfortable with the characteristics of the provider, excuse me, and vice versa. Think about intertreatment support, right? We mentioned that. Think back to our discussion of bias and stigma as well. So what are the opportunities for improvement in these areas? Affordability, availability, accessibility, accommodation, and acceptability. Okay, move that. And then opportunity number 5, right? Myths and misconceptions. So here's a quick true-false quiz. Don't weigh in on this, all right? Just think about it. Don't weigh in on this, just think about it. True or false, right? Tobacco addiction is not as serious as other real addictions. True or false? Chantix causes suicidal thoughts. True or false? NRT medications are highly addictive. Tobacco treatment doesn't work. Most smokers don't want to quit. You can't use NRT and smoke at the same time. You can't use more than one NRT product at the same time. Pregnant women must never use NRT. If you smoke with the patch on, you'll have a heart attack. Nicotine causes cancer. All right, do I need to go on, right? Every one of these is false, all right? These are the myths and misconceptions. Some are just old and research has proven otherwise, but they persist. They're still out there, believed by many, including many providers. So one of the best things we can do is to bust these myths and misperceptions, and training and education can do that. Okay, so now it's time to put the thinking caps on and try to figure out, What can we do better? All right, I'm going to call this section Standard Care Plus. So remember, standard care is a combination of counseling and medication. How can we reinforce and supplement standard care, especially in the low SES population? So expand high-speed internet access, enhancement number one, especially in the rural areas. So the good news is that we're already working on this. Maine's Governor Janet Mills has focused on expanding affordable high-speed broadband across the state, especially in rural areas. So Governor Mills proposed and signed into law the Maine Connectivity Authority, a new entity charged with achieving universal availability of high-speed broadband in Maine. When we think about access to care, internet access is one of those critical items, whether it's connection with the Maine QuitLink or telehealth appointments or accurate information or community or peer support. High-speed internet access is absolutely essential. So let's make sure everyone is connected. Enhancement number two, what are the unique characteristics of your patient population? Standard care is baseline, right? But sometimes you need to consider the specific wants and needs of specific groups. The low SES population is one of those groups. So providers should be sensitive to this particular challenge that this group faces, not only from the SES standpoint, remember, but from all the other drivers of health, including education access and quality, neighborhood, environment, social and community context. So targeted training can increase the understanding and sensitivity necessary to develop effective interventions for this group. So targeted training. Enhancement number three, provider learning community. So training is great, but what about after training? Like, how does one stay sharp and get support? So provider learning communities enable participants to engage in a virtual community with their peers, where they share support and guidance and feedback. As a result, their collective understanding of how to disseminate and implement best practices with respect to tobacco treatment continuously improves and expands. It's clear how this would benefit providers in rural areas. There are also some existing forums that providers can join, such as various eco-type projects. And as always, CTI offers the complete menu of training and continuing education for providers. So enhancement number four, in my 16 years plus of providing training and education to healthcare providers on evidence-based tobacco treatment, I've heard the same comment over and over. And here it is. There are no support groups for tobacco users in my community. And this is unfortunately true. They are few and far between. CTI has put together a tobacco treatment services guide, which is available on our website, that lists all of the services that we know exist, organized by county in Maine. This is one area where we could enhance treatment for tobacco users. There may be services we don't know about. Find out what's available in your area. If you find something that's not in the guide, let us know and we'll include it. And who knows, maybe after being trained as a tobacco treatment specialist, you might want to start your own support group in your community. Enhancement number five. Now, it seems logical that in rural areas, if a patient can't get to services for a variety of reasons, bring the services to them. So mobile health clinics generally focus on prevention and primary care, providing health screenings and vaccinations and physical exams, chronic disease management and education, and all those kinds of things. And let's not forget mobile dental clinics. So why not tobacco treatment? Even if you bundle it with other services, it's still an improvement. And wouldn't a dedicated mobile tobacco treatment van be absolutely cool? And then enhancement number six, believe it or not, right, this has already been tried. A program in Australia installed vending machines in hospitals, and they were used, NRT vending machines, mostly by people who couldn't smoke while they were in the building, like visitors and staff, but they were used nonetheless. So remember, we're trying to increase access to care, right? And this might be something to think about. And we already have vending machines for Narcan, the opioid overdose medication. So how about for NRT? And the patch and the gum and the lozenge are over the counter, safe and effective. So this is a really good idea, just to think about. And then enhancement number 7, all right, peer support. So another comment I hear frequently is the value of peer support and recovery. And make no mistake, right? Recovery from tobacco use disorder is exactly the same as recovery from any other substance use disorder. So peer support makes people feel less alone and in the company of somebody who has firsthand lived experience to share openly and honestly. It's a vital part of the peer process and can be reassuring for both parties. So adding peer support to the array of tobacco treatment services is a great enhancement to standard care. Okay, so we have talked about the prevalence. We've talked about standard care, evidence-based tobacco treatment. We've talked about risk and protective factors, or as we call them, opportunities and optimistic facts. And we've talked about some of the enhancements that we might make to standard care. We call it standard care plus, particularly for this particular population, this low SES population. So I wanted to take just a couple of minutes and I'd like to hear from you. I'd like to hear, what do you think it could be possible? What do you think might work, with this particular population that would provide that enhancement to standard care, provided that little extra boost that could help bring effective tobacco treatment to this group. So I want you to think about that a little bit. And if you want to come off mute and just share, I mean, you could do that too. Is that possible, May, for people to come off mute?
Nope. Just
It's
type in the
not,
chat.
it's not possible. Okay, sorry about
Correct.
that. Got excited there for a minute. But yeah, use the chat feature and let's just brainstorm for a little bit. Throw something at the wall, see if it sticks.
While folks are thinking, Edward, we actually got a different question in the Q&A box. So
Oh,
if you don't
sure.
mind, I'll ask
No,
you that, and then we'll go
not at
back to
all.
the chat.
Okay.
So Adrian wants to know, if someone has Berger's disease, can they still use bupropion and varenicline, or is that off limits as well?
As far as I know, right, as far as I know, there's no restriction on using bupropion or varenicline since those are non-nicotine medications. But I would always want to check with the healthcare provider before making that recommendation to people. But as far as I know, yes, they can use those medications. Excellent question.
Awesome, thank you. And we're getting lots of feedback in the chat.
Yay.
So let's see. Some folks have said incentive programs.
Yes. Yes.
Partnerships with employers offering opportunities for support, NRT use at work.
Yes. Excellent. I love that.
Providing community outreach, such as support education groups.
Yes. Very good.
And somebody says we're working on vouchers for NRT for our patients that are uninsured or underinsured. This is through charitable funds at our hospital.
Wonderful. What a great idea.
And tobacco counseling brought to subsidized housing.
Yes. Wow, this is a brainstorming group. This is excellent.
And more coming in, helping with other factors associated with SES and tobacco use, such as ACEs, food insecurity, mental health.
There you go. Yeah, so it's not, again, it's really not just the SES, it's all of those other drivers of health. And I did not mention in this presentation, I did not mention like trauma-informed care, but I think that's also, as you referenced ACEs, it's also something that's really key. I think we should be providing trauma-informed care in all cases anyway, because people, it's like a universal precaution. People have experienced trauma. We're not asking them if they have, we're just assuming that they have. So yeah, I think that's an excellent point.
I'm not seeing anything else right now. Oh,
That is a super list. I'm blown away by that list. Thank you so much. I wasn't sure what kind of feedback I was going to get on this. I'm very impressed.
health education classes in schools.
Yes.
Decrease the economic stressors that lead to smoking as a calming agent.
You know, that's a really interesting comment because, you know, as I was doing the research on this particular presentation, I did come across a lot of commentary that said, look, if we want to reduce the burden on low SES populations, let's address the SES issue, right? Let's not address how to better provide tobacco treatment to this population. Let's address why this population is in that condition in the first place, right? Why are they low SES? What can we do to address that? That's the root cause, right? It's not so much the tobacco use disorder is more of a secondary issue, right? And we're doing well with that and talking about how we can address that and how we can do something about that. But let's address the root causes as well. So poverty, education, communities, all those types of things. Excellent. Yes.
And Keith said it's important to advocate for and support policies that address the root causes of income and social disparities.
Keith, I set you up on that one. No, you set me up on that one. One of us set each other up. That was perfect.
And then another idea, health departments working with economic security departments to bring classes to those wanting to quit.
Excellent. Yeah, very good. Now, I do want to make just a little comment here before we wrap up. And, you know, I called this model Standard Care Plus, and we talked about the low SES population, but I think we could think about this more broadly in terms of any population that we're working with, right? So if we're working with an educationally disadvantaged population, we're working with veterans, or we're working with pregnant women, or working with Native Americans or Alaskan Natives, or any other group, LGBTQ, for example, what can we bring to bear in terms of the plus part with them as well? And all of these things have very common themes in them and very common roots. And I think we could do very well by applying this to all that as well. But that's excellent. Yes, thank you so much.
And make the Surgeon General warning bolder, like in other countries, and all marketing the same.
Yes, standardize. Absolutely.
And that's all I'm
Are we
seeing
going to be
right
able to
now.
say, May, are we going to be able to save this chat?
Yes.
Yeah, I'd like to save this chat. And if it's possible, is it possible to get this back to our participants today in some way, shape, or form? We'll think about that. Yeah, we'll think about that because these are all great ideas. I don't want to lose them. You know, I want to get them into your hands so that these could be the genesis. They could be the seed of a lot of good stuff in the future. Well, this has been excellent. Thank you so much for participating and listening and providing all of that excellent feedback. I do have another question for you, and this is the confidence scale again. And I just want you to think about this. This is your own, for your own, you know, self-reflection. Ask you the same question on a scale of 0 to 10, with 0 being no confidence at all, 10 being as confident as you can possibly be. How confident are you right at this moment that you have the knowledge, skills, and abilities to effectively help low-income clients become tobacco and nicotine free? And I hope that by spending this short time together, that we have moved the needle just a little bit. And that brings us to the end of the presentation today. As always, we're happy to hear from you with any questions, comments, or suggestions. Here's our email. And here's my closing thought for you. We're all individuals, we're all unique, and we're all different in our attitudes, values, and beliefs. But there's one way we're all alike: the desire to help others find their own path to health, vitality, serenity, and recovery. So thank you for being here today, and thank you for all the good work that you do. You make a difference. Thank you.
Thank you, Edward. I will give folks another minute or so to type any lingering questions that you may have in the Q&A box, since we have a couple minutes left. You're getting lots of thank yous in the chat, Edward.
Thank you, and you're welcome.
Let's see if we get any questions in the next 30 seconds or so, and then if not, I'll just do the closing and we will be finished.
Excellent. And I'm actually interested in looking at the chat by seeing all those things that are interesting about you guys, because I haven't been able to see any of that yet. So, but I will look at it.
All right, so I'm not seeing, not seeing any questions come in. Thank you so much, Edward, for such a wonderful and informative webinar. Once again, everyone, this webinar was recorded and will be posted to our website. In order to claim CMEs, you must have a profile in Cloud CME. Instructions can be found in the post-webinar email. And for those that are collecting CHES credit, a record of your attendance will be sent to NCHEC on your behalf after the event. Again, only those who registered for the webinar, connected via the Zoom link, and attended the full session will be able to receive credit, as we are required to verify those who attended. You will also receive all of this information, a copy of Edward's slide deck in a post-webinar email. And additionally, an evaluation will appear on your screen once the webinar is closed. Please take the time to provide your feedback. And if you have any questions, like Edward has posted on the screen there, please reach out to us at our tobacco training email. And Edward, I actually did just have another question come in,
Sure.
if you don't mind, since we have a couple minutes left. So Danielle asks, how do you keep momentum or focus on tobacco when you have new things like opioid crisis?
I think it's just a matter of having more than one primary focus. You know, for example, the opioid crisis, I use this example occasionally in training, and I will ask, you know, how many people die each year as a result of opioid overdoses and things like that. And the number is around 100,000 or so. And how many people die each year as a result of tobacco-related disease? And the number is about 500,000. So it's a matter of keeping the focus on what is important, and both of those things are extremely important, right? But one is not more important than the other, right? Opioid addiction is the same addiction as tobacco use disorder, the same addiction as alcohol use disorder, any other substance use disorder. They're primary, progressive, chronic, and deadly diseases, both of them. So we can't say, for example, oh, we're just not going to deal with this one because this one's more important. We have to have both of them in front of us at the same time. I know that makes it more difficult and it makes it more challenging, but I think that's also the reality of what we do. When we deal with people who have addictions, it's a hard job, and it's very challenging, and it's very takes a lot of energy, takes a lot of dedication, takes a lot of empathy, a lot of compassion, and I'm sure every one of you listening to this has all those things in droves. But that's the case, right? We just have to keep the focus and understand that this is something that we need to do. It's something that we need to address. We need to figure out the best way to do it.
Awesome. Thank you, Edward. And I am not seeing anything else. Lots of chats have come in with lots of thank yous. So it's hard to see if there's any questions, but I don't believe we've missed any. But again, folks are more than welcome to reach out to us at the email on our screen there, and someone from our team will get back to you. So again, thank you so much, Edward, and thank you everyone for joining us today.
Thank you. Have a good day, everybody.
Take care.